Right. Go ahead, Jeffrey.
Oh, maybe if Jeffrey's right. Okay. Yeah.
Hi guys. Right now, I don't know if you can hear me well. I'm not at home, but I'm really excited to be part of this session. I don't know if you can hear me well.
Yes, we can hear you well.
Great. So yeah, I'm also very excited to present a new case for today, and I hope everything gets something out of this meeting. And yeah, so I also encourage everyone to participate in the chat box if you want.
Yeah, and I don't know if Sandra or Guillermo want to say anything. Um, if not, we can start presenting the case with the first piece of information.
Perhaps,
Well,
Guillermo?
I just
Yeah,
wanted to
go
say
ahead.
that I'm very excited.
Great, great. We are also excited, Guillermo. Um, yeah, let's begin. Let's begin with the case. Why don't you present your screen, Jeffrey?
Okay, guys, can you give me 2 minutes, please?
Yeah, I think we can give you 2 minutes and we can start. I think we can start discussing the chief complaint since it was already revealed to everyone. Yeah, let me join with my other device. Yeah, great. Much better. Yeah. So, in the meantime, while we wait for Jeffrey to present his screen, when I heard that the discussion was going to be about visual hallucinations, I knew that it was going to be a very interesting discussion, just because visual hallucinations are no, or sorry, not visual hallucinations, because they can be of any nature. Visual hallucinations is just one of the types of hallucinations that a person can have, and I think the pace and the localization it's going to be very useful for determining the final diagnosis. Um, so I don't know if Jeffrey, now do you feel comfortable starting with the case right now?
Yes, I do. Okay, so I'm going to present the B1. Okay, so this is the chief complaint today. It's a woman presents with hallucinations. Do you want me to reveal more information, or should I
I, I
do?
think I think we can start from here. And well, I was doing a little bit of an introduction, but I don't know if you Arturo want to comment first, or do you want me to comment first?
I think the last time I commented first.
Yeah,
So
yeah. So I think I can start. So when a woman presents with hallucinations, I mean, I do have some biases. So if I'm faced with a clinical situation where I find a woman that's very young that presents acutely with hallucinations, and I would like to first know the content of those hallucinations, what type of hallucinations they are, and the course that these hallucinations have, because it is not the same a patient that has hallucinations that come and go than hallucinations that started at some point in her life and have continued and progressed till this day. But some biases that come to my mind that I just want to mention for the sake of um, pre-grad medicine. It's, for example, hallucinations can be part of a delirium stage, they can also be part of an episode of psychosis, and that psychosis can be triggered not only by common diseases that cause them, like schizophrenia, but they can also be triggered by drugs, and legal and illegal ones. And they can also be triggered by any kind or any etiology that can trigger delirium, right? Because we are talking about a potential alteration in the content of the consciousness, and that is going to be and the type of content of the consciousness that is involved, I think it's going to be determinant in for us to try to localize the lesion. So, for example, if this is the case of a woman presenting with visual hallucinations, I would be suspecting something that is affecting the occipital cortex and also parietal cortex, and the gray matter and the white matter can be affected, and by a specific type of lesion that we don't know yet, that can be causing these hallucinations, or they may appear as hallucinations. It can also be a primary psychiatric disease, and those are not really well localized, but that can also be the case. Something that we should remember is some diseases have involvement of the central nervous system. Though some systemic diseases have involvement of the central nervous system, like lupus, for example, which can cause episodes of psychosis and seizures. So it is also important to have a detailed history of the presentation of the patient. And I don't know if Arturo, you have more comments to add. What do you think about what I've just said?
Yeah, no, I completely agree with you. And maybe for as how will I approach hallucinations is by thinking whether the hallucination is either auditory, visual, maybe gustatory, tactile hallucinations. I think that to some diseases, that's determination of which sensory modalities first affected is very localizing. But to other processes, to other diseases, it doesn't matter which sensory component is affected, because some diseases, for example, Parkinson or Lewy body dementia, present with all those types of hallucinations, either auditory, either tactile, either visual hallucinations. So maybe the first approach will be to determine which type of hallucinations the patient has, and then try to be more specific with which disease the patient may have by taking all the possible info from the history, from the neurological examination, from the past medical history, maybe the context of the patient also, if he is taking certain medications, or if the patient is in risk of consuming drugs, or if the patient tells us that the patient is consuming drugs. So maybe that is a very big clue. Also, I think that we can approach hallucinations by trying to determine if this is a peripheral process or a central process. And that is maybe something that I just learned recently, because when I heard hallucinations, the first thing that came to my mind is a central process, because that is the hallucination is an altered perception of a non-real object. And that is obviously in the brain, in the cortex of the brain. But there are certain types of hallucinations that present with peripheral processes. For example, a patient that is completely blind can have visual hallucinations, and that is the case of the Charles Bonnet syndrome. Also, the patients that became totally deaf can have auditory hallucinations. That is also the case, for example, for the alien lip syndrome, which is this case of the patient that can control his arm and feels like that arm has a completely life separated of that person. That is also a type of hallucination, a tactile hallucination, and a peripheral disease that disconnect that sensory modality from the brain can present also as hallucinations. And all the other causes are central causes. Schizophrenia is a central diffuse cause. The delirium is a central diffuse cause. Also, focal causes that can affect, for example, the parieto-temporal occipital part of
Temporal.
the also,
Okay.
the temporal occipital part of the brain can present with hallucinations, tumors, strokes. There are really a lot of diseases that can present with hallucination. It's very, 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 very wide. So I think that now we have put a little bit of what in which context we can find hallucinations. So maybe we're ready for hearing the history of the patient.
Yeah, please, Jeffrey, tell us more.
Okay, guys. So now I'm going to reveal the first part of the primary history, and then we're going to further details of what happened afterwards after the entry. So an 82-year-old woman complained of noticing blue flashes in the right lower quadrant in both vision fields, along with oscillopsia and mild dysarthria. She also complained of difficulty reaching for objects with her right hand and off-balance gait. Symptoms started 2 days before.
Hmm. Yeah, why don't you, Arturo, tackle this second piece of information, and then I'll complement.
Yeah, there is a very very interesting point of information. So you before mentioning the case of a young woman that came present with hallucinations, for example, by lupus. Now that we are seeing a elderly woman, it is very important to say that in elderly patients, in the context of hallucinations, between all the causes that can be more prevalent in this ethnic group, for example, strokes, we can also start to thinking about dementia in its variable presentations, for example, in Parkinson, or also in Lewy body dementia. So that is perhaps one of the first things that we can say after seeing the age of the patient. Now, blue flashes in the right lower quadrant in both visual fields. Perhaps it is very important also to determine that visual hallucinations can be either simple hallucinations and also complex hallucinations. Simple hallucinations are for example what the patient is telling us that those blue flashes are more likely to be simple hallucinations. Complex hallucinations are more elaborated images, for example, seeing people, seeing animals, seeing objects that are not real. Seeing geometrical images or use lights or use flashes are simple hallucinations. These type of hallucinations are presented, for example, in migraine, in migraine with aura, presented with simple visual hallucinations. The localization of the hallucinations in the right lower quadrant in both visual fields with oscillopsia and mild dysarthria. Now, when I heard that these hallucinations are presented in a very specific quadrant of the visual fields, I start to think about focal disease in the occipital lobes. The right lower quadrant in both visual fields may be a presentation in a bilateral occipital hemisphere disease. But we can also perhaps say try to localize a little bit before in the visual pathways. Maybe the level of the optical chiasma and the optical radiations. The dysarthria is really something that escapes from what was I thinking before, because dysarthria, we can say that it may be a disease of the peripheral nerves, also in the central brainstem, but I don't find a specific place where I can have visual hallucinations and dysarthria. So if a focal process is a little bit difficult to localize in this patient, I may start thinking about other diffuse causes. For example, demyelinating causes that can present with hallucinations by demyelinating plaque in determinate in specific places in the brain, and it is widely known that demyelination can also present with dysarthria. So that is what I am gonna say for the first sentence. Do you have something to add, Gerardo?
Yes. So just to complete the HPI, she also complained of difficulty reaching for objects with her right hand and of balance gait. Symptoms started 2 days before. So what's very interesting is the hyperacute nature of these deficits, right? Um, it's very interesting that an 82-year old woman has such a complex clinical presentation that just started 2 days ago, because most of the diseases that we are talking about tend to manifest a little bit earlier than we would expect. And as you pointed out, one thing that we should have in mind is dementia. The other thing that I would argue even is my main suspicion would be delirium, just because delirium has many causes, especially in geriatric population, right? The localization, the how can I say it, the symmetry of the involvement of the visual fields. It's very interesting to me, because when we hear these types of symmetry, as you said, we suspect, okay, maybe the lesion is past the optic chiasm, but this doesn't seem to be like the case that's dissected just by thinking about the optic pathway, right? Because how can you reconcile an involvement of the visual pathway and also the dysarthria? It seems like there are we are claiming a lot of strategic lesions that can be obviously present in a patient, but I just would be very cautious thinking like that, because I know that that's very unlikely. So this um, this type of presentation in the acute nature, one of the things that that I can suspect is, for example, also de novo seizures that this patient can have, and de novo seizures can be explained and mostly by structural lesions in this age range. For example, I remember that, or we can remember that amyloid angiopathy, it's a problem that increases its incidence with age, and amyloid angiopathy tends to affect primarily the parietal and occipital cortex. So maybe we can add that into our differential diagnosis, because ischemic injuries in these territories can have different manifestations than the typical stroke, right? Because the typical stroke that we think about, it's the one where it's accompanied with weakness of some sort and alterations of sensation of some sort. But these parts of the brain that can be affected have different manifestations, as we associate them, especially, well, the structures that are irrigated by the posterior circulation. So right now we can suspect some localization, mainly in the posterior circulation. We are claiming that it can potentially be an involvement of the occipital lobe and brainstem, and also the off-balance gait can also be representative of an insult to the cerebellum. Obviously, this is a very this is a claim that has a really broad differential diagnosis. So also, I would also be cautious. because off balance gait can be a lot of things. Can be weakness, can be apraxia, can be ataxia, etc. But since this is a case of acute presentation, and I would, I think I would prioritize stroke versus seizure due to a structural cause. But I'm excited to learn more about the case from Jeffrey.
Okay, great discussion so far. It mentions lots of important points that are being pointed out, teaching points as well. Okay, great. I'm going to reveal more information. So over the next weeks, the visual field defect expanded into right homonymous phenopia, and optic ataxia also developed at the left. Dysarthria and dysphagia worsened until she was dependent on tube feeding, and cognitive changes were also noticed. So yeah, she started presenting dysarthria and dysphagia, and she had to get tube feeding.
Interesting. So I think it's my turn to start, right? Yeah. So the visual field defect expanded into a right homonymous hemianopia. So when we talk about visual deficits and we talk about right homonymous hemianopsias, it can localize to the optic tracts and the occipital cortex, mainly, and the lateral geniculate bodies also. And when we talk about a specific involvement of the territories of the posterior cerebral artery, then we add the characteristic of the macular sparing, but the macular sparing isn't being referred here. And this, as this case is being uncovered, I don't think this is the case of a simple ischemic attack due to whatever cause of a stroke it can be in this type of patient. I think it's a more complex case because we also have optic ataxia also developed on the left. I remember that optic ataxia can be explained by lesions in the perioccipital cortex that is in charge of coordinating eye movements. And you know that you have structures that are in charge of the pursuit of objects. You also have structures that are in charge of the saccades to direct your eyes to a specific stimulus very fast. That is a saccade. And the structures that are involved in the eye movements are primarily the frontal eye field in the frontal lobe and the perioccipital cortex. And so this optic ataxia can be a reflection of an involvement in that region, and the fact that this is happening in a geriatric patient and a woman makes me just be more confident in my differential diagnosis. But I know that it may change throughout the case as we learn more about the physical examination, because since the dysarthria and dysphagia worsened, that tells me that there's more let's say like a more heavy involvement of the brainstem. That's something that we can assume that if it is a bigger, that there's a larger damage to the brainstem, why aren't we hearing other types of symptoms like weakness? Because in the brainstem, all of these structures that are coordinating the movement, etc., are condensed there, and it is very rare that just a specific nuclei get involved and the other tracts and nuclei are spared. So that's something that makes me think, okay, maybe we can consider the hypothesis of a peripheral nervous system cause rather than a central nervous system cause. But right now, I would prioritize central nervous system causes, and obviously, I would remain thinking that this is a case of an acute hyperacute presentation, and our main differential should be a stroke versus seizures. And Arturo, what do you want to add?
Yeah, I actually like the hypothesis of a stroke. May also because the patient is having more symptoms than before, and things that can get complicated that way can be an ischemic stroke complicated with a hemorrhagic conversion that can that can make more severe the symptoms of the patient. Something that I really liked to hear was the explanation of optic ataxia. It is a very interesting symptom, and that also reminds me of Balin syndrome, the combination of optic ataxia, visual apraxia, and
Simultagnosia.
yeah,
Mhm.
and that is, as you said, due to perioccipital lesions. But in the case of Balin syndrome, they are bilateral.
Uh-huh.
So it is very interesting to see optic ataxia in this patient. We haven't seen the patient was having difficulty reaching objects with her right hand. Could that be a visual apraxia? Maybe. But we aren't seeing the classical simultagnosia that is also found in these patients. But any going forward, that the patient is having something in the perioccipital part of the brain also, maybe in the left part of the brain. So cognitive changes was something also that I found interesting, because there is a combination of symptoms that can make us think in Lewy body dementia, and that is the cognitive component, the Parkinsonism, and the hallucinations, the visual hallucinations. In this patient, we have the visual hallucination, the cognitive changes. The Parkinsonism is not very established so far. And as Gerardo said before, this type of dementia are chronic processes. In this case, we are seeing a very acute process. So maybe really a stroke is a very important cause. All other causes that came to my mind due to the focality of the hallucinations and the cognitive changes are, for example, tumors that can present acutely with a hemorrhage and can present in acute way. Other causes, for example, the thing that I found most difficult to try to to put in the syndrome of this patient are dysarthria and dysphagia, because those are two symptoms that doesn't fit very well in the localizations that we are trying to put right now. And with that, we maybe start to consider other processes. For example, embolic strokes from endocarditis can present with a lot of type of embolic strokes that can perhaps present with the hallucinations, the hemianopia of the patient, also the cognitive changes, and may also cause dysarthria and dysphagia. So for trying to approach to the diagnosis of the patient, we really have to do a really great exam, a really great past medical history, a familial history, and also the neurological examination to try to find any cause that can explain this variety of symptoms in this patient. So with that, I think we can go to the past medical history. Go ahead.
Yes, I agree. Jeffrey, please share with us more information.
Yes, guys. So far, I'm really liking all the neurological terms that you're mentioning. So I'm going to go to past medical history. So I have a patient who was diagnosed with hypertension 5 years ago and gastric reflux 2 years ago. She also contracted COVID and was hospitalized in 2020. As for the meds, she takes irbesartan and ranitidine. Should I reveal the family history and also the physical
Yeah,
exam?
I think to be mindful of everyone's time, I think you can
Yeah.
reveal.
Okay, family history was unremarkable, and the social history, she didn't take any drugs or alcohol and didn't have any allergies. For the vitals, temperature was 37.2, heart rate normal, blood pressure 126/76, and respiratory rate 18. For the exam, she had normal weight, although was mildly malnourished due to feeding tube dependency in the last weeks. Not cyanotic, not icteric, slight facial expression that was reflecting emotional lability. Head, eyes, ears, nose, throat, no alterations. And cardiovascularly, she had no jugular vein pressure sign, no edema, normal heart sounds, and no rhythm, and normal rhythm, and no murmurs. Um, she had clear palpitation lungs bilaterally, and her abdomen was soft, not tender, and there was no organomegaly. As for the extremities, there was no edema, but there was some mild muscle wasting that was detected in both upper and lower limbs.
Great. And yeah, Arturo, why don't you start with the discussion from this piece?
Yeah, so the past medical history, the hypertension. Something that came to my mind after hearing hypertension was this disease PRES, posterior reversible encephalopathy syndrome, which is related to hypertension, but it usually presents with headache. And it's very interesting because PRES can present with hallucinations. It is very related to occipital white matter disease due to the hypertension. And that is why it can cause visual hallucinations. But all the times that I have here press have came with headache. So
Yes. Yeah.
after away from that hypertension, it is a very recognizable cause of strokes. But in this case, I don't think if we are seeing really only focal causes of strokes. But it is very important to say that hypertension may be a cause for the possible strokes if this patient really has strokes. The family social and allergies doesn't really take us to anywhere except put away drugs, put away alcohol. In the general examination, also in the examination of the other systems, we have put away other causes that can present with multifocality disease in the brain and in the brainstem, for example, the endocarditis, because the patient has normal murmurs. And even knowing that endocarditis can present with normal murmurs is really, really, I think, put back in the list right now. Also, other causes that can present with focal diseases in the brain that are a cause of a systemic process. I think all those diseases we have put it back in the list because there is really no other clinic in the patient, except maybe for the emotional ability that can be attributed to the central nervous disease, and also the mind muscle wasting in a patient of that age. Malnourished is really not of a surprise. So really, I think that the most important thing that we have to determine now is if this patient is having acute confusional state, delirium, and we are going to see that with a neurological exam, and also determine whether the patient was having a cerebral process or a sensory ataxia due to that imbalance that we saw in the history, and also to determine whether the patient is having other neurological symptoms that I think can lead us to determine specifically which syndrome we are seeing. That is what I have to comment. Do you have something to add, Gerardo?
Great. Yeah. So, as many times before, we asked about risk factors for stroke, and this patient sure has some risk factors. Although the diagnosis of the hypertension it's quite recent, and we haven't heard if the patient has been having a good adherence to her treatment, which can really determine the likelihood for her to have an ischemic event due to the hypertension. Aside from that, we don't really see a lot of signs that can point us towards another direction, and other than the malnourishment and the muscle wasting that can be expected in, or that the prevalence of those problems is increasing with age, right? Sarcopenia, it's a problem that affects a lot of geriatric population. Um, yeah, but so far we haven't really our thinking hasn't shifted that much, and we agree on the importance of a good neurological examination to see if we can find clues of a different process than what we are hypothesizing, right? And so I think we can I think we can hear more from Jeffrey. Go ahead, please.
Yeah, great, guys. I'm really loving the discussion so far. Thanks for revealing neurological information. So, on her mental status, the patient was alert, oriented. Her Glasgow Coma scale was 15 out of 15, but short-term memory got impaired over the weeks, and mild paranoia was also present. The last days prior to this clinical story, the last days she presented with mutism and akinesia. Um, as for the cranial nerves, the pupils were equal round reactive to light. Her extraocular muscles were normal. There was mild dysphagia and right homonymous hemianopia. There was no nystagmus and no sound constellations or wasting. And there was no facial asymmetry. As for the sensory function, there was normal sensation and normal paresthesia. And there was mild weakness or difficulty with her right hand, which also could be like attributed to her optic ataxia. As for the reflexes, over the last days, she has developed generalized hyperreflexia. And for her coordination, she has difficulty with right hand coordination and also right-sided optic ataxia, which is difficulty for reaching for objects with her left hand. So she has like both hands. She has a deficit for coordination in both hands. And her gait was also unsteady, as mentioned in the examination picture. As for her speech and language, she presented with dysarthria, and she developed mutism over the weeks. As for her special signs, orthodoxy was found to the start, and myoclonus developed more and more over the course of her impairment. And this myoclonus was induced by light touch and noise.
Okay, so there are a lot of things to unpack here, and well, I think I will start with what surprised me the most, which is that the mutism that this patient is presenting, because that's something that I haven't heard in that many diseases, and the mutism can obviously be triggered by something that is directly involving the structures needed to generate language. But it can also be elective mutism that can accompany some primary psychiatric diseases. But due to the hyperacute nature of this presentation, then I will prioritize structural causes of mutism. I remember that mutism was characteristically presented in HIV, in the neurological impact of HIV in the I remember that manifestation, and it can also be due to the worsening of the clinical picture of the patient that started with dysphagia, and now the patient just can't produce any more movement in the region. Also, something that was important was the generalized hyperreflexia, That type of a statement makes me think of a diffuse process affecting the central nervous system, and this diffuse process affecting the upper motor neurons globally, and that can trigger some hyperreflexia. Although in in some hyperacute causes of this, we can see initially spinal shock with generalized hyperreflexia before the hyperreflexia starts, which is not the case here. That we are just hearing a straightforward and generalized hyperreflexia. And the coordination, the right-sided optic ataxia. Well, we Arturo and I have commented a lot of the possible etiologies that can cause damage to the parieto-occipital cortex and trigger this type of presentation. Um, and yeah, well, the oscillopsias. To be honest, I don't really know how to localize oscillopsia. I know that, if I'm not mistaken, it's like a subjective perception of movement, just like vertigo, but milder. But yeah, if someone has a better input than that, please feel free to share it in the chat or open your mic. And the myoclonus is something that we tend to link with metabolic processes, and I asked to myself, well, but in this type of patient, we can claim a possible metabolic cause, and I don't, to be honest, I don't really know, but maybe we will uncover more and more of the case and see if there's a possible link between those two symptoms. But yeah, that will be all. That's all that I wanted to comment on this last piece of information. Arturo, what do you want to say about this?
Yeah, it got really complex right now, because now it's not just the focal process in some part of the brain, because there are a lot of things that go out of that. For example, the hyperreflection. How can we establish a hyperreflection in a patient with visual hallucinations? It is very difficult to do that. But some processes that came to my mind, that, as Gerardo said, diffuse CNA diseases, CNAS diseases, for example, encephalitis perhaps, or a disease in the brainstem that affects the upper motor neuron pathways that presents with hyperreflexia. But as Gerardo said, that without weakness, it is very difficult. And the only type of weakness that we are seeing in the patient is the weakness that is more difficult with the right hand, and that is due to the optic ataxia, and that is more likely to be a central nervous system processing the left parieto-occipital part of the brain. So the hyperreflexia is really something concerning. With dysarthria and dysphagia, something that I was thinking before is maybe if we can try to think about dysarthria and dysphagia not just as brainstem and peripheral causes, but as a general type of weakness. And a weakness, as we always approach, can be a brain, can be a brainstem, can be the nerves. Perhaps there is some time of brain disease in this patient that is causing the dysarthria and the dysphagia in this patient, but it is more likely to be something also in the brainstem that is presenting with these two symptoms. Away from that, the patient doesn't have any sensory symptoms, so that also makes us doubt about brainstem process. But with the dysarthria and dysphagia, we can really do much. But as try to expect from the imaging that we see something in the brainstem and something in the brain also. So I think really the imaging is really going to be very important to try to establish the diagnosis of this patient. As for now, the syndrome that we are seeing is a very wide syndrome, very special distributed diffuse syndrome. presented with a lot of different symptoms, different signs. Something that I also wanted to add was about thinking about diffuse processes in the brain. AIDS is one of the causes that came to our minds seeing this. Without fever, without any other opportunist infection, this may be a little bit difficult, but HIV dementia or HIV diffuse process in the brain can really be told now. But also we are seeing an alert and oriented patient, so that really makes it a little bit difficult. Other diffuse process in the brain that is usually associated with sensory symptoms, but can also present with central nervous processes, is vitamin B12 deficiency. Can really present with a lot of ways in the nervous system. Very likely to present as a diffuse CNS process. But as much as we are seeing a diffuse process in very different localizations in the brain, we are really seeing some part of those that are very focal. So I think that the possibility of multiple strokes shouldn't be totally totally excluded right now. So I think with that we can go to notable labs and imaging. Go ahead, Jeffrey.
Yeah, I do think so. And one of the things that I just a brief comment that I wanted to make, it's that I don't know how to reconciliate the mutism with the Glasgow being 15/15, because you have to have verbal response. And this patient, if the patient had 50, it means that the patient had appropriate words and was oriented in time and space. So maybe if the mutism can be described more better, that could be helpful. But yeah, I think Jeffrey wanted to comment about that, and then please proceed with the notable labs and the rest of information that you wanted to share for us in this moment. Selective mutism. Okay. Selective mutism. Interesting. I've heard about selective mutism, and that accompanies some psychiatric diseases. I haven't heard of, well, and I also heard about the, let's say, neuropsychiatric complications of HIV, as Arturo and I mentioned before. The Glasgow Common Scale score was 50/50 at the hospital entry, but it decreased during the internment. So we have a progressive decline in Glasgow Common Scale, which doesn't really, I mean, it can tell us that the level of consciousness may be deteriorating, but it will be more helpful if we knew which specific domains are declining. Like, it's not the same for a patient that still localizes pain or withdraws for pain, or a patient that has inappropriate words on uncomprehensible words. And so, as we know, that the three components of the Glasgow scale, yeah, it was due to the selective mutism. Yeah, so we are now learning that the selective mutism was the cause of the progressive decline in the Glasgow Common Scale. And well, that selective mutism, that to be honest, I don't know 100% how to interpret that in this clinical picture, but I don't know if you, Arturo, want to make a comment about that, or should we proceed to the notable labs to be mindful of everyone's time?
Nah, I really don't have anything to add. I think we can go to the labs.
Yeah, great. Go ahead, please, Jeffrey. Yeah, okay. I can read it. Yeah, so For the notable labs, we have hematology and other blood tests. This patient had leukocytes of 7,920, hemoglobin of 11.5, platelets and 190, 100, and 90,000, sorry, HIV negative, PDRL negative, ANA positive, 1 over 160, anti-DNA negative, ANCA negative, normal C3 and C4, normal ESR and RCP, TSH normal values, vitamin B12 normal values. Chemistry, that sodium may be 136.8. I don't think it's 1036, 100 and 300, no, 1368 sodium. I don't think that. That may be a mistake. And potassium is 4, bicarbonate 24, BUN 42, creatinine 0.7, glucose 105, calcium 9.2, albumin 3.5. CSF has a clear appearance, glucose of 52, proteins of 34, red blood cells count of 3 in the CSF, white blood cells count of 2, it may be my understanding that there's no, you haven't found any organism on the CSF. That's what I interpret from the gram negative. Oligoclonal bands were absent. CSF panels, E. coli, influenza, Neisseria, meningitis, Streptococcus galactiae, Strep pneumo, CMV, HSV, India Inc., Toxoplasma tumoral markers, they were all negative. So, what do you think, Arturo, from these labs?
Yeah, I think that after seeing all of these labs, we can really put all our hopes in imaging, because we are really seeing anything in these labs. There isn't any index for suspicion, any infection. There is any abnormalities in the electrolytes. There is any clue in the CSF. We only saw ANA positive, but that is really something not specific enough. So we are really seeing anything that help us approach the diagnosis now. So maybe really the only thing that we can expect is seeing the images of the brain stem, and really interpret those findings. I don't know what do you think, Gerardo?
Yeah, I'm also a little bit lost, just because I think what's happening to us, and it's totally understandable, is that we don't have an illness script that encompasses everything that we have found in this patient, and that is okay. Sometimes that happens. I've heard even neurologists being lost at a new type of presentation that hasn't been told to them before. So what I can say from this panel is that, well, it's a very complete panel. It explored a lot of possibilities that we were discussing, mainly autoimmune diseases, demyelinating diseases, and infectious diseases like HIV, which were found negative. And well, the ANA, without any other positive serological study, we can't really interpret that or translate that into the clinical context to try to explain this case. And yeah, the CSF, it's negative to everything. And what it tells us is that there may not be inflammation in the CNS itself, or that the inflammation, it's very targeted, very localized to specific structures. Because let's not forget that this patient has a homonymous hemenopsia, and the homonymous hemenopsia there are no other causes than the structural causes of a homonymous synapse. It is a very a specific lesion that points us towards the structures that are posterior to the optic chiasm. So, with that, I would say there has to be an structural lesion somewhere in the regions of the parieto-occipital temporal cortex, and maybe in the white matter or the gray matter, um, and those the pathological processes that are causing this may be uncovered in the next piece of information when we hear about the imaging. Yes, so I don't have anything more to add, and I think we can have the next piece of information, please, Jeffrey. Do you want us to read? Yeah, we can totally help you out. So for this imaging and other diagnostic tests, we have the EKG and chest X-ray, which showed no abnormalities. The electroencephalogram showed mild diffuse theta range slowing with periodic sharp wave complexes, and the MRI showed volume loss was apparent bilaterally in the occipital-parietal regions, as we were suspecting. So that may mean something, right? And diffuse weighted imaging showed cortical signal abnormalities, most apparent in the left occipital lobe. No other abnormalities were detected, including post-gadolinium images. So it's interesting everything that we we have heard right now. The I don't know what to make up of the theta range slow and periodic sharp wave complexes. I know that some types of encephalitis have some specific patterns that can be identified in the electroencephalogram, although it is not the study the study that you would select to diagnose an encephalitis, which is diagnosed with a lot more of uh, clinical tools that one can have to suspect that, not only imaging, not only electroencephalography. And the MRI, well, the volume loss, especially in the occipital-parietal regions that are bilaterally, makes us think of this famous syndrome that Arturo claimed in the past, and we were using sort of the anatomy to explain it, the optic ataxia and the deficits in the eye movements affecting the bilateral occipital-parietal regions, the Valin syndrome, right? And the diffuse weighted imaging cortical signs, signal abnormalities, most apparent in the left occipital lobe. Well, the way that it is reported with cortical signal abnormalities, I wish there were more specific the description of the signal abnormalities, because diffusion weighted imaging is a sequence that is mainly used to detect diffusion restriction, and this diffusion restriction can be identified with those two sequences, which are diffuse weighted imaging plus ADC. And well, we don't have the ADC sequence at the moment, but it may be indicative of ischemic lesions. So I think, well, the fact that the post-gadolinium didn't reveal more something else about the lesions I think puts further away the autoimmune demyelinating hypothesis, which are normally enhancing in the acute phase, right? Which is the case right now. So I don't know if you have anything more to add, Arturo.
Yeah, so with the EAG, maybe we can think about that the process that is in the brain is maybe causing a little bit of seizures, and that is maybe that can explain the EAG. With the volume loss bilaterally, I think with that, I to my mind came what you said before about CAA, about cerebral amyloid angiopathy, that I think can present it that way, but it is mainly found as a lobar hemorrhage. We don't see lobar hemorrhage, but we are seeing the volume loss. Other thing that came to my mind with volume loss are the dementia syndromes, Alzheimer. I don't think this patient fits with Alzheimer. I don't think it fits with any dementia at all, because dementia are chronic processes. But if we try to maybe say something about that, a disease that can present with the Balin syndrome is the Lewis body dementia. Lewis body dementia that can cause the Balin syndrome. The DIY imaging, as you said, is mainly used for the cytotoxic edema that is found in ischemic strokes. And that causes a restriction in water motion in the interstitial space, and that causes the restriction of diffusion. And if we will, if we try to look at the specific description, we don't find it here, only with abnormality in diffusion. But maybe that is the description that this case report is using for restriction in diffusion. So maybe a stroke also. And with all that, and the differential diagnosis that came to my mind are CAA, are a stroke, perhaps the Lewy body dementia. Another process that I started to think, seeing the presentation of the patient that got really sick very fast with with her symptoms progressing really fast, is dementia by Creutzfeldt-Jakob. I don't know if that is has
Mm,
specific presentation since the MRI, or if there is any symptom that is not in the patient for thinking about that. I don't know what do
yeah,
you think?
because there were I do remember that Creutzfeldt-Jakob disease was accompanied by startle myoclonus, and we have heard about the myoclonus present in this patient. But the fact that the hyperacute nature of this presentation, it just doesn't really fit well with me with the illness script of Creutzfeldt-Jakob disease, which tends to be idiopathic, ergo it is not really caused by anything detectable. It There are some genetic susceptibilities for it, and you can certainly get it if you have contact with tissue with prions in it, or you consume that type of tissue. But you're right, that is a degenerative cause that we should have in mind. Although the incidence is very low, it's like one case in a million. But the fact that this hospital, Mogrovejo, or the Instituto Nacional de Ciencias Neurológicas, receives references from the whole country. I've seen a couple of cases there, so I may be biased towards that diagnosis. But yeah, that's my final comment. And I don't know if it's right for us to assume that this was the last a piece of information for us, and the next is going to be the final diagnosis. Can you reveal to us that, please, Jeffrey?
Yes, guys. Sorry that I couldn't talk before. I am really proud of what you discussed so far. I don't know if you want me to show the pictures, the MRI images, but I
Yeah,
think
please,
you've discussed them very well.
please do.
So here it is. And as you've said, there was this perioccipital lobe degeneration, and that could explain the symptoms of the patient, the optic ataxia. Actually, you could argue that she had Valiant syndrome. Nevertheless, the other two components were not found. Sorry, they were not described, but they probably could have been found. Okay, and also there is like a generalized degeneration as well. There is not only localized to that part. Okay, so I do have another test.
Go ahead, please.
If you need any reference for this, you could also ask for it. So
yeah, the protein. Yeah.
go ahead.
So, yeah, why don't you comment about it, Arturo?
So as I understand what is in what is in the PPT is the protein gets low in the following days. Is that Jeffrey? Is that so? Or what do you mean by 14, 4, and 3 protein in CSF?
Yeah, I think he's referring for these proteins that is a common test performed with Creutzfeldt-Jakob disease patients. That is a biomarker of Creutzfeldt-Jakob disease, and it turns out to be positive. I think that it is a common misconception about that protein that it is specific. I think that it's not that specific, but it is rather more sensitive. But that may be right, that may be wrong. I don't really remember. But I do know that it is a biomarker of Creutzfeldt-Jakob disease. That's because the Creutzfeldt-Jakob disease is caused by an accumulation of an abnormally folded protein that triggers the misfoldment of other proteins in the brain and causes generalized insults throughout the whole brain parenchyma. And that can be really rapidly progressive. And we can see a progression since the start of symptoms to total loss of consciousness and death in a patient in less than 1 year. It is a very aggressive disease, a very aggressive neurodegenerative disease. And yeah, as I said, I have seen like a couple of cases myself, and that's what I don't really remember that at the top of my tongue. Yeah, or I didn't claim it in the first part because of how the case was described, and also my own biases as well. But now that you've mentioned it in the past, Arturo, I think we can strongly suspect that this is a case of Creutzfeldt-Jakob disease. What do you have to add, Arturo?
Yeah, I didn't know that was the protein that is tested for Creutzfeldt-Jakob disease. That only came to my mind as a MRI not a specific finding and rapid progressive dementia. That is how I was having pictured Creutzfeldt-Jakob dementia. But it is really, really, really great to learn something new that every day. So I think with that we can go to the final diagnosis. Jeffrey, go ahead.
Yes, guys. Okay, so yes, actually, the CSF 1443 protein, it can be used for Lyme disease, but also for Creutzfeldt-Jakob, and as Gerardo mentioned, it's more like sensitive. Approximately, it's about 60% sensible for Lyme disease. Nevertheless, it's very used broadly. Although there are like other tests that can help you out and which are more specific, like sorry, this one's kind of hard to pronounce. RT quick.
Yeah,
but like that's very, very very expensive.
Very expensive.
And as Gerardo mentioned, yeah, I've also heard of this during my rotation, but like yeah, of course we don't have improved. Okay, so I'm gonna reveal the final diagnosis. So product representation, we had an 82-year-old woman with hypertension who experienced rapid onset visual defects, dysphagia, myoclonus, and cognitive deficits, which led to mutism with a progressive course and imaging showing volume loss in the occipital parietal regions. Okay, so for the diagnosis, because of the imaging and factors and the acuteness and progressive course of the disease, the patient was suspected to have sporadic Creutzfeldt-Jakob disease, or SCGD, SCJD, which was confirmed with a post-mortem neuropathology analysis. So the patient did get to have a more severe clinical state. So she had dysphagia, she had dysarthria, she went on to have selective mutism and also akinesia. So she couldn't move. She had these. So her mental state deteriorated, and she, because of the severeness of this disease, and also because there isn't a treatment for this disease that can help us change the course of the disease. The patient did pass away after 3 months. Now, Creutzfeldt-Jakob disease must be suspected when thinking about rapidly progressive dementias, which the patient did have. I know, probably it would have been better if we had or if I had pointed out better that the patient had her short-term memory impaired over the weeks during her hospital interment. So yeah, and that united to the fact that she presented with myoclonus is very, very suspectful of this. Now, Creutzfeldt-Jakob disease can be presented with, okay, so you have this short-term memory impairment or the rapidly progressive dementia. That differentiates this disease from other dementias, which of course progress over the course of years, like Alzheimer's disease. And there are also some types of Creutzfeldt-Jakob disease that develop during throughout years. But Creutzfeldt-Jakob disease is 80% of cases is caused sporadically, and the other 20% comes for the familiar types of Creutzfeldt-Jakob disease, which include, for instance, the familial sleep. There is this disease which also doesn't let people sleep.
Yeah.
And that is also a type of Creutzfeldt-Jakob disease. And there is a small 1% that goes for acquired Creutzfeldt-Jakob disease that, for instance, comes from eating prions, which are the other proteins that cause Creutzfeldt-Jakob. And that can be found in human brains, but also through cows. So you have the mad cow disease. Nevertheless, those are, of course, less common. So, and also because of the patient had 82 years old, so approximately around the age, the onset, the average age for Creutzfeldt-Jakob is 60 years old. And the clinical, how you would suspect of it clinically, includes dementia, as I mentioned, and also myoclonus, and some other affectations, like, for instance, visual hallucinations. You also have optic ataxia, which is also included, and the patient and gait ataxia. So the patient in this case included all of those symptoms, which is not common. Usually a patient only would include myoclonus or optic ataxia or visual hallucinations, along with the rapidly progressive dementia. So in this case, it was weird that the patient had all of the symptoms that made you suspect of Creutzfeldt-Jakob. So, but the only way to confirm it is through histopathology, and also we have the exam here. I'm gonna open it up, and that shows the alterations that Creutzfeldt-Jakob disease causes I'm gonna show it to you. Okay, here you have it. No. Okay, so you have certain okay, so these are from patients, and you have
I don't think you are presenting your.
yes.
Now we can see.
So you have spongiosis. That is a very characteristic trait of Creutzfeldt-Jakob, and that means that the gray matter is scattered, and there are vacuoles that are formed, like for instance here. And now you can also use immunohistopathology to detect prion proteins, which they did, and here you see them stained. And these are vacuoles, for instance, and this is called term spongiosis. Like these are the characteristic traits of Creutzfeldt-Jakob. And this one is from Ambos that I took, and you could also see the spongiosis that is characteristic of the disease. Okay.
Great. Oh, I think Jeffrey closed his window of the meet in accident, but while we wait for him to return, I think this was a very good discussion. I think I learned to include in my differential diagnosis of a rapidly progressive cognitive decline, of course, this degenerative cause, very well known for the steps, but not really that common, but very interesting to analyze and to learn from, which is Creutzfeldt-Jakob disease and the whole spectrum of neurodegenerative diseases due to the accumulation of abnormal proteins. So I love the case, and thank you so much, Jeffrey, for presenting it, and thank you so much, Arturo, for co-discussing with me. And I don't know if Guillermo has a brief statement to make about the teaching points that he did. Just a brief comment to be mindful of everyone's time. Yeah, we noticed, Jeffrey. Don't worry. Don't worry. It's okay.
Well, I think that I like to say that it was a very interesting case. There was a lot of differential diagnosis, and I found it really interesting.
Yeah, great. Yeah, so I don't know if anyone has any closing statements to make. If not, I think that will be all for today's session. And thank you so much for everyone. Jesus Gutierrez, Dr. Gutierrez, yeah, you're welcome to open your mic and share your thoughts.
Thank you, Gerardo. If everyone talks in Spanish, I can make some comments about the case that was so interesting.
Yeah, podemos hablar también en español.
Okay.
Claro que sí.
Para hacerlo más rápido. Es un caso muy interesante. No sé si es que puedes poner todo el caso en general. Yo me presento, soy Jesús Gutiérrez, soy residente de neurología de segundo año del Mogrovejo, del instituto. Fue un caso muy interesante. Tal vez puntualizar algunas cositas. Es una paciente de 82 años. Entonces ahí se abre, pues, como dijeron inicialmente, ¿no? Muchas patologías en la cabeza, dependiendo de, puede ser neurodegenerativas, puede ser algunas agudas como strokes, ¿no? Cuando lo presentaron, claramente llamó la atención la focalidad, ¿no? Como le dijeron al inicio, ¿no? Una cuadrantamnosia, ¿no? Me pareció inferior derecha y hace pensar en stroke. Siempre recordarnos que los infartos generalmente dan síntomas negativos, ¿no? Hemiparesia, hemipoestesia, déficit visual. Y lo que ahí escapaba un poco de todo eso, las obsiloxias, ¿no? Las obsiloxias, como lo mencionó Gerardo, es la presentación, el síntoma que tiene el paciente de un nistagmus, ¿no? Generalmente, ¿no? Es un nistagmus, ¿no? y generalmente no está tan acompañado a un infarto cerebral, un stroke, si es que este no es en cerebelo, digamos en los pedúnculos cerebrales o en los núcleos vestibulares. Es una paciente adulta mayor que inicia de forma medio aguda, de 2 días, síntomas, focalidades, ¿no? En realidad es una focalidad, pero hace también síntomas cognitivos, ¿no? Entonces, siempre hay que tener en cuenta cuando tenemos un paciente con alteración de funciones superiores, estamos, uno, a considerar causas agudas. Dentro de eso es lo vascular. Si es que esto no es agudo, súbito, pero está progresando, entonces ya no pensamos tanto en algo vascular, sino en algo infeccioso, autoinmune, ¿no? O, como hemos visto en el caso, cuando hay progresión de los síntomas y se agrega otras funciones superiores, ya hablamos de una demencia. Y si es así rápida, como lo han mencionado, es una demencia rápidamente progresiva. Entonces, cuando tu paciente ahí hace también el mutismo y la quinesia, esto también lo podemos agrupar como una catatonía, ¿no? El mutismo y la quinesia son presentación de un síndrome catatónico, ¿no? Entonces, yo lo agruparía así. Y lo que siempre hay que acordarnos que la triada de Creutzfeldt-Jakob es la triada de la demencia, ¿no? La ataxia y las mioclonías. Siempre cuando tengamos un paciente con un deterioro cognitivo, rápido, agudo, subagudo, generalmente de 6 meses a 2 años, que es la definición, tenemos que considerar la enfermedad por priones, que es la Creutzfeldt-Jakob, siempre. Por eso siempre cuando tenemos paciente con un deterioro cognitivo, buscamos, ¿no? Evaluamos la parte cerebelosa en busca del ataxia y evaluamos también la parte de las mioclonías, que es muy típico, es la presentación es más típica. Entonces, desde ese momento también me llamaba la atención, esto podría ser una enfermedad de Creutzfeldt-Jakob. Lo interesante de su caso, que también tenía síntomas visuales, ¿no? Alucinaciones visuales, que es el síntoma inicial, ¿no? Y las opsiloxias. Entonces, las variantes de Creutzfeldt-Jakob, una de las variantes es la variante de Heidenhaut, lo voy a escribir en el chat, que dentro de las variantes de Creutzfeldt-Jakob, esta es la variante que le llaman la visual, porque se presentan con alucinaciones visuales y algunos síntomas, digamos, visuales, como por ejemplo los axiloxias, los nistagmos, ¿no? Entonces, el diagnóstico final de este paciente, sería mucho más bonito ponerlo así, es una enfermedad de Creutzfeldt-Jakob, variante Heidenhaut, con presentación fenotípica de un síndrome de Balin, porque ha completado es un síndrome de Balin incompleto, no ha hecho la simultagnosia, pero se cataloga como síndrome de Balin, ¿no? Entonces, es un caso muy bonito, también lo refería, ¿no? Dentro del laboratorio clínico, siempre con un deterioro cognitivo rápido hay que descartar la parte metabólica, ¿no? Porque podemos estar dentro de una encefalopatía metabólica, un delirio, que claramente con el examen se descarta, con la punción lumbar descarta lo infeccioso. Lo autoinmune también es muy importante, ¿no? Las encefalitis autoinmunes también son demencias rápidamente progresivas y no hay que olvidarlas, ¿no? Siempre un deterioro cognitivo rápido, que descartas lo metabólico, alguna infección, algún delirio, tenemos que también considerar, uno, las encefalitis autoinmunes, ¿no? Se hace la punción, no hay un claro componente infeccioso, se le pide su panel tanto viral, bacteriano, negativo. Entonces, en este caso, pues sí estaría adecuado hacer una resonancia magnética, ¿no? En la resonancia magnética, si es que lo puedes poner, hay signos típicos, ¿no? De enfermedad de Creutzfeldt-Jakob, ¿no? Eso es lo que es muy importante. Cuando tenemos a estos pacientes, la resonancia es una de las ayudas diagnósticas más importantes. ¿Por qué? Porque el electroencefalograma se puede hacer y te salió un hallazgo típico que son las ondas periódicas agudas, que sí se ven, pero no es tan frecuente, ¿ya? Pero lo que sí vamos a tener son estos hallazgos. Este es el protocolo de difusión, como dijo Gerardo, este es el protocolo ideal para ver isquemia, ¿no? Pero es el protocolo más importante para detectar signos de la enfermedad de Creutzfeldt-Jakob, ¿no? Se ven en la parte cortical, van a ver que hay restricción, ¿no? Hay restricción, ¿no? Hay restricción. Esas son un realce hiperintensidades en las zonas corticales, como pueden ver, ¿no? Occipitales principalmente, por ahí veo en la parte parietal del lado izquierdo, ¿no? Entonces esos son signos típicos. O sea, en el Creutzfeldt-Jakob vamos a ver en la corteza cerebral, la sustancia gris se va a ver más blanca, más hiperintensa, y también zonas subcorticales del putamen y el núcleo caudado, ¿no? Incluso te da los signos del palo de golf. Yo le voy a pasar a Gerardo unas fotos de imágenes de pacientes reales del instituto para que los compartan, donde van a ver claramente los signos. Entonces, siempre buscamos eso. En la parte cortical, en el protocolo de difusión, realce cortical, focal, como este caso posterior y más del lado izquierdo, y se ve también en la parte cortical el famoso palo de golf o hiperentesiosis de putamen y caudado. Entonces, con eso, presentación clínica de deterioro cognitivo rápido, ataxia, mioclonías, incluso una resonancia así compatible con reace cortical, esta es una enfermedad de Creutzfeldt-Jakob, ¿no? Porque muchas veces, como mencionaron, la proteína 1433 en el Perú está a 3.000 soles, ¿no? Y generalmente es un estudio que se hace y te llega a los 2 a 3 meses el resultado, pero actualmente, si es que algo hay que llevarnos acá, que ahora tenemos el RT-Quit, ¿no? El RT-Quit es el examen ideal para pedir, incluso ya en el ROER, a partir de unos meses, hace unos 2, 3 meses ya lo tiene, y te llega el examen en 2 a 3 semanas, tiene mucha mejor sensibilidad, mucha mejor especificidad, y eso ya ha reemplazado por lejos a la proteína 1433, entonces hay que tenerlo en cuenta. Y como mencionaron, para terminar el electroencefalograma, lo más característico son las ondas trifásicas, ¿no? Entonces, también eso es importante, si queremos profundizar más de esta enfermedad, lo que hemos visto, ¿no? Son ondas periódicas, ¿no? Agudas, que en inglés las iniciales son el PSWC, y que son típicas, incluso si lo llamamos, hay más variantes, ¿no? De la MM1 y la MB1, pero se ven. Pero lo que hay que llevarnos, que en enfermedad de Creutzfeldt-Jakob nosotros buscamos las ondas trifásicas en el electroencefalograma, que también te ayuda, ¿no? Si no me equivoco, se ven en un 60-70%, ¿no? De los casos, pero es un poco raro, pero sí se pide. O sea, en tu plan de trabajo con una demencia rápidamente progresiva, ¿es indicado el electroencefalograma? Sí. ¿Es indicado hacer la punción lumbar? Sí. ¿Es indicado la resonancia? Sí. Incluso deberíamos hacer también electromiografías, ¿no? Si bien no han dicho algún hallazgo de segunda neurona, fasciculaciones, también hay encefalitis autoinmunes que se presentan con alteraciones neuromusculares, ¿no? Entonces, también una demencia rápidamente progresiva, pedimos también electromiografía buscando alteraciones de hiperexcitabilidad del nervio periférico, porque un diferencial de Creutzfeldt-Jakob son encefalitis autoinmunes que son muy agudas, así como muy agudas, como son los anticuerpos Caspar-2 y el G1, que se presentan algunos como morba, ¿no? Encefalopatía, ¿no? Alteraciones neuromusculares. Entonces, siempre eso en nuestros protocolos, en tu atención, cuando tú tengas un paciente, hay que pedirlo, ¿no? Porque a veces no se mira, porque hay que estar bien revisando todas las extremidades del paciente, ¿no? Pero también dentro del protocolo es pedirle, ¿no? Entonces, eso es lo que yo quería mencionarle. Este es un caso muy interesante y una presentación muy atípica. Es una enfermedad de Creutzfeldt-Jakob con una presentación de la variante, que la voy a escribir de una vez antes que me olvide, de esta variante, y presentado con un fenotipo inicial de un síndrome de Balin, incompleto, pero sí, ¿no? Entonces, es un casito muy, muy interesante y obviamente muy raro. Gracias, es lo que quería comentar.
Muchas gracias, doctor Gutiérrez. Creo que todos los aquí presentes apreciamos bastante el input que ha dado para este caso. Hemos aprendido incluso más de lo que inicialmente habíamos discutido, así que muchas gracias, doctor, y es totalmente invitado para tenerlo en las siguientes discusiones, ya sea discutiendo, presentando o como usted quiera colaborar con este espacio. De la misma manera, todos los que nos han acompañado hoy están invitados también a poder involucrarse más activamente en esta actividad. Um, I think it is a little bit weird to switch from Spanish to English, but I just wanted to do it for the sake of the recording because we are ending the session right now. So we are, as I said, very thankful to everyone for your presence today, and we expect you to accompany us in the next sessions. I don't know if anyone has any closing statements. Arturo and Jeffrey, or if not, we can end the session right now. And that will be all for me. Thank you so much and good night.
Yeah, I just wanted to say that thank you, Dr. Gutierrez. It was really amazing how you explained us Creutzfeldt-Jakob disease. It is a really, really interesting disease. Thank you also for explaining us the Heidenheim variant of the disease. And thanks to everyone for attending today, and I hope to see you all in the next session in 2 weeks. And if anyone is interested, the link is in the chat for you to access and to put your name in the date that you want to participate. always considering that all the discussions are on Thursdays and is every 2 weeks, so you have to choose either from now to 2 weeks or from there to 2 weeks. So you have that in the form send it in the chat. So thanks everyone. I hope to see you all in 2 weeks.
Thanks everyone. Goodbye.